Welcome everyone to another virtual shouting session at Hearts for Health. Hopefully you enjoyed your weekend. There's been quite a few now in the summer. We're almost done, just 2 more months. That's pretty crazy to say, but today we're joined by Aurthi. She's a practicing PA in emergency medicine and orthopedic surgery. I do have a few reminders for y'all. I know that quite a few of y'all have joined in who are new to our sessions. We have had quite a few PAs on the program, and I know quite a few of you might have caught on and heard about our program. So just to familiarize you with our format, at the end of each one of these presentations for the session, we do have a Q&A. And for any questions that you might have for Aurthi or any future speakers, feel free to type them in the chat. We have that chat either to the right or bottom of the live stream that you're viewing right now. Another thing is we do have an Instagram page where you can catch us for all the flyers, all the announcements we have for upcoming virtual shouting sessions. We typically have them on Mondays and Thursdays at 7 p.m. Central, although there are some sessions that do deviate from that timing. And also you'll get the information on what those speakers specialize in. Are they PAs? Are they doctors? We've had some dentists. We've had some nurse practitioners on virtual shouting before. So you'll get to hear a little more about our speakers before the actual sessions. So that's just a great way for you to stay tuned with us. Another way is through our listserv. That listserv is something that you can subscribe to. It's a weekly listserv sent out on Thursdays. And we have a subscription form at the very bottom of each one of our pages. So if you hop onto our website, and that's going to be hearts4health.org, scroll to the very bottom on any of our web pages, you'll see a subscription form at the very bottom, and you'll fill it out, click submit, you'll be ready to go. If you happen to have a little trouble finding that subscription form, please do feel free to email us. We're happy to help out. Our email is community@hearts4health.org. We do have a few programs we're going to be releasing this August/late July. So if you happen to be interested in those also, feel free to reach out with any questions. We have a couple of volunteering programs, some being remote. So whether you're international or in any state in Canada, whatever it might be, you can join in on those volunteering programs. And we also do have a virtual mentorship program. So definitely something to not to miss if you happen to be interested. But with that said, those are all the reminders. Feel free to email us with any questions. I don't want to take up too much time. So Aurthi, take it away.
Thanks, Michael. Hello, everybody. I know you guys have heard from a few of my PA colleagues, so hopefully this is a bit of a generalized but also a specific perspective on ortho surgery. I believe Saf may have covered emerge a bit. So again, I like to title it as what is a physician assistant, because it is something that we get asked often as a growing profession in Canada. But I am happy to say that more and more years I practice as a PA, the less I get this question. So that kind of shows the growth that the profession is going through, and somewhat exponentially over the last few years. So as Michael said, I'm Aurthi. I am a practicing physician assistant. And I work in ortho surgery and emergency medicine. I'm also the academic coordinator for the University of Toronto Physician Assistant Program. I always say this at the start because I don't know like how many of you are interested in applying for PA school, and I get a lot of questions about application process and stuff. I just want to put this out there that there is a conflict of interest in terms of discussing anything application related, but I hope that this sheds some light on the profession, which is a great profession, and kind of helps you decide on your career path. And then just to note that I did work as a registered kinesiologist prior to pursuing the PA profession. So I do have experience in kind of MSK in that background, which kind of led me to the PA route and specifically ortho surgery. So I kind of jumped ahead, but I'm going to go back here. I don't know, Michael, if you can help me with this, but in terms of a pre-presentation poll, if you can even get it in terms of numbers in the chat, I'm just curious to see how many of you have heard of or are considering the physician assistant profession as a career option. So I know you guys had some exposure before, but in case we have some new people on with this, but in terms of
I'm going to be reading out responses I see from the chat, but while we're at it, if y'all want to also put where you're coming from, what state, or if you're from Canada, feel free to add that in too.
Great.
there's a little bit of a delay. So if you want to hop on to the next slide and we'll circle back. That might be
Sure,
good.
no worries. Yeah. So, I mean, even for this question, we can see how many are considering the profession, since you guys have potentially heard of from my colleagues. So I will skip ahead, and then Michael, feel free to interrupt whenever. So I will jump into my journey. So you can see that first off, there's a lot of different stages, but I really like to highlight that it was not a linear path. So starting off in the red top left, I started off as actually an aspiring tennis player. I wanted to go professional. I was competing internationally when I was 13, and most of my time was spent on the tennis court more than in school. And I did gain some transferable skills, whether it's like, hard work, discipline, resilience, things like that are on court that I was able to transfer to school. And it was actually a shoulder injury, which kind of like pushed me to make that transition. So I kind of missed the critical window to go pro, and I started shifting my focus into school, which was actually a big, steep learning curve. Because I made the transition as I wrapped up middle school and went into high school. And in grade 9, I was trying to figure things out, catch up. And first couple of years was like that. And then in grade 11, I took the specialist high skills major program, which is the SHISM program, specifically focusing on health and wellness. So my interest in health and wellness kind of sparked from being an athlete. And then I was kind of drawn towards those science courses. But then specifically in grade 12, I took the exercise science course, which was focused on human anatomy and human physiology, which I was like, okay, this makes sense. Like you can actually apply it to yourself. It's more like gross anatomy instead of something that's more specific, like you would learn in bio and chem. So I found that to be interesting. I also did a lot of volunteering in high school, whether it was helping to coach on the tennis court or at the walk-in clinic, physio clinics, gift shop, and so many different areas. I actually started off in the retirement center, so that was one that was very close to heart. And all of these experiences kind of helped me decide on what to pursue for undergrad, which was a degree in kinesiology. I did the science stream, and I also did a minor in medical sciences because I took a lot of the science courses. And this was at University of Western Ontario. So I did 4 years there, took a lot of science courses, as I mentioned. I also played varsity tennis, so my injury was somewhat better, not back to 100%, but again, trying to maintain that variety and maintain that school life balance. Also did some coaching, which taught me some skills, which I use to this day in clinical teaching. I also participated in a lot of extracurriculars, so I did Habitat for Humanity mission trips to Louisiana to help with Hurricane Katrina and Hurricane Sandy, like the damages from that. I actually attempted the MCAT, which is like the med school admissions exam twice. And it's funny because like both times I was like, I'm just doing this to keep my options open. All my friends around me were like determined to go to med school, but I did it to keep my options open because I was interested in medicine, but wasn't entirely 100% set on med school. So then came the debate between what other I guess med school and PA school. And I actually landed on the PA profession, or even that there was such a profession in 4th year, which was somewhat later than I would have wanted. So I'm in 4th year trying to figure out what to apply to next. And I did, it's every time I say this, it's funny, but I did a Google search about like career options that are similar to doctor, but obviously, putting in like shorter schooling, less financially, all those different things that, that make you hesitant to pursue med school. And the PA program at University of Manitoba popped up, and I was like, okay, this can't be real. Called up my mom. I was like, there's apparently something called physician assistant, and I did not know such a thing existed. And then that kind of started me, looking into the profession and exploring that option. And it just clicked. Like I knew that's what I wanted to do, but now it was about kind of confirming that interest by going and putting myself in an environment where a PA is kind of working and seeing what they do day to day. But also since it's 4th year, I didn't have the time to kind of apply that year. So what am I going to do for my year off? So my degree really helped me with that. So with the kin degree, I worked as a kinesiologist. I worked at 2 physio clinics, and I also did some tutoring to keep in touch with the academic side. I did apply to the States, which prompted me to kind of take the medical terminology course because it was a prerequisite for some of the schools. And I think my most important valuable experience in that year after undergrad was doing PA shadowing. So I basically reached out to one PA in endocrinology, asked to shadow them, and from there networked to shadow a PA in neurosurgery, general surgery, radiation oncology. So it was like a breadth of experience to see how PAs function in different specialties, which then helped me kind of like see what kind of roles I could kind of take on in the future. And that just consolidated my decision more to pursue PA school. So I got into one school in the States and then 2 schools in Canada, and then came the debate between going to the States, staying home, and then which school. So I wanted to stay closer to home. And I also wanted to pursue the U of T PA program because I liked the curriculum. I found it to match my learning style. So I would say, like, if you're in that position, and those are kind of the reflections and pros and cons lists that you would want to go through to decide what school is best for you. And then came PA school. So I started PA school September 2018. And again, I mentioned some of those deciding factors, and I really liked that U of T program was also in the downtown Toronto area. So there's a lot of networking opportunities where a lot of PAs were already practicing there. So I could do one-day placements or rotations, but also just kind of being surrounded by somewhere where other interprofessional healthcare professionals like know about PAs. So whether that's like doctors, physios, nurses, so many different other like allied health professionals, so I could work alongside and learn alongside them while I do some of these placements. So that's kind of one of like the many factors that helped me decide on PA school. And then I'm sure you guys have heard of how intense the curriculum is. I basically compare it to like 4 years of med school is condensed into 2 years. You don't get much of a break. Your 2 years of like the didactic content is like basically compressed into 3 semesters. So to give you an idea, first semester, you take courses like anatomy, physiology, the foundational courses. Again, this is speaking to the U of T program. So that's first semester. And then you have the clinical skills part 1, where you start learning about history taking and different clinical skills such as that. And then second semester, you take pathology, pharmacology, diagnostic techniques and procedures, courses that will help you kind of bring together some of that foundational knowledge to clinical medicine. And then third semester, we have a medical foundation course, which you go through different modules like endocrinology, cardiology, nephrology, all those different specialties almost in a way. And you tie everything you learn into like clinical context and patient cases and how you would diagnose a patient or how you would investigate further or manage a different conditions. So that's didactic year. And then second year, you do clinical placements. So it's total 10 placements, a lot of them in 4 specialties. So it's family medicine, you do general surgery, psychiatry, internal medicine, pediatrics, and there's one more. And Emerge, of course. How could I forget Emerge as your core rotations? And then you have some room to do elective rotations as well. And then among amidst this intense curriculum, you're also trying to do other extracurriculars and network and kind of create job opportunities for yourself while putting yourself out there as a PA student. So once I finished and graduated from PA school in November 2020, I had to kind of decide what specialty to go in. So one of the perks of being a PA is you get to choose like whatever specialty you want to go to, whether it's general medicine as like a family med PA or emerge med PA, or you can choose like specific specialties, whether you want to dive into ortho surgery or general surgery or endocrinology, cardiology, so many different options. And I decided on emergency medicine because I thought that would be great to kind of get a few years of emerge under my belt. It is a very intense specialty, but it kind of is a good specialty when you're starting off your career, high intensity. So it keeps you on your toes. And so that's kind of where I started off. And then after my first year in undergrad, an opportunity came up to do ortho surgery. So it was to cover one of my classmates for her mat leave. So I did 1 year of ortho surgery, and then an opportunity came up to stay involved in ortho. So now I'm half emerge and half ortho. So that's a little bit about my journey. We can, if we have any updates on the poll, we can cover that before I dive into the next slide.
Yeah, so far we have one person from Michigan who's interested or who has heard of the PA profession, unsure of pursuing. But yeah, that's all we've heard so far.
Okay, cool. Okay, so I've been saying PA, physician assistant, so much. So what exactly is a physician assistant? I don't know if you guys caught the on the very first slide, I did have an office reference at the bottom. So it's not assistant to the physician. It's important to know that you're kind of serving as a physician extender. So physician assistant or PAs are like highly skilled healthcare professionals, and you're actually, they're educated in the medical model, as I mentioned earlier, and they're trained as generalists. So the scope of practice actually mirrors that of their supervising physician in whatever specialty they work in. So this includes conducting history and performing physical exams, ordering and interpreting investigations, performing diagnostic and therapeutic interventions. So that is to say that the PA can diagnose and treat illnesses, and they can prescribe some medications under medical directives. But keeping in mind that certain places you can't prescribe narcotics. And then lastly, and most of like one of the more important points is that they have a big role in educating patients on different treatment options and counseling for preventative health. And I think this plays an important role because when you add a PA to your practice, you free up the time for the doc as well. So let's say you have 50 patients, a family doctor gets 50 patients a day roughly, and you're adding a PA to your clinic. So you almost half that workload, or even if you take 30 and you give 20 to your PA, it's more time with the each individual patient, which is more quality patient care. So you don't feel rushed. There's more time to educate and counsel on different preventative health aspects. So the diet, like a patient comes in for a refill of their diabetes medications, you actually have that extra time to talk to them about exercise and nutrition and what other ways that they can kind of like manage conservatively instead of just focusing on refilling the prescription meds. So that's kind of the gist of like the general scope. And then it's also important to know that we PAs can assist in surgery and perform procedures. So surgery and ortho, like assisting with joint replacement surgeries, and you're in the OR with the surgeons. And then procedures such as suturing, incision and drainage, casting broken bones and fractures in the emergency department. So PAs can basically do all of that. And again, that reflects that scope of practice similar to their supervising physician, or physicians could be a group as well. So as I mentioned earlier, PAs serve as physician extenders. So they extend the physician service. They're not really personal assistants for the docs. And with that being said, you can work relatively autonomously, but it is important to note that we're not independent practitioners. So we serve as an extension of the physician, but we're not independent practitioners like a nurse practitioner or the doctor themselves. So in terms of settings, you can find a PA in a hospital setting or clinic settings. And it's also important to make the distinction that PAs go by physician assistant, or in Canada, we say CCPA. So that's Canadian Certified Physician Assistant. I believe it's PAC in the States, which is a different designation, but we never go by doctor. So I wouldn't say I'm Dr. Aurthi. I would say the PA Aurthi, or you just go by your first name. So that's kind of a bit about PAs. Now, specifically, what does a day-to-day look like in the two different specialties I work in? So I'll start off with emerge, and then I'll dive into ortho surgery. So emergency medicine PAs or EDPAs, we basically do shift work. So the way it is emerge is open 24/7. You're expected to, your shifts kind of adjust to provide as most coverage as you can within that PA group at your hospital site. So your shift it's usually 10 hours at the site that I'm at, and it usually starts anywhere from 8 a.m. And so 8 a.m. to 6 p.m., or the latest would be 6 p.m. to 4 a.m. And so again, that kind of highlights that it could be a day shift. There are afternoon shifts like 1 p.m. to 11 p.m., or it can be a night shift from 6 p.m. to 4 a.m. I know certain hospitals, they actually do 11 p.m. to 9 a.m. So that's like a full overnight shift. So again, when you choose emerge, you do have to do shift work, which can be a pro for some or a con for some if you're not much of a night person. But it does give you some flexibility where you're working, where you're not working on a weekday. So you get to wander around the mall when it's like quiet and everyone else is working, or you're actually working on weekends where everyone else has time off. So there's pros and cons to that too. When you work in emerge, you're essentially frontline in the hospital. And I like to make this nerdy anatomical reference that the emerge is kind of like a thalamus of the brain. So when something comes in, it kind of directs it to the right department. So if you have a patient who comes in, let's say with appendicitis, then you're that first person who assesses them, and then you direct them to general surgeon to do the actual surgery and manage them appropriately. So there's a lot of interprofessional collaboration, whether it's with consultants, so any different specialties like specialists, or within the department, you work alongside nurses, pharmacists, social workers come in. So there's a lot of opportunity to collaborate, and you actually collaborate with other providers as well. So if you have a case that you're kind of like thinking about, then you can even discuss it with your colleague, emerge like doc or like another PA, and kind of see like what their thoughts are on the case and get more kind of collaborative approach to it in that sense. There's also referrals. So even when you see someone and you're like, I don't really know, like let's say a patient comes in, classic story, chest pain, and ECG is normal, blood work's normal, and you're not too worried about them, but you still want them to get a workup, then you can refer them to a cardiologist, and then the cardiologist will see them in clinic and do the appropriate specific workup for that specialty. So there's also that opportunity for outpatient referrals as well. In general, emergency medicine is general medicine. So you see everything and anything that walks through the door. And in terms of management, there's a good mix of medical management as well as procedural management. Some of the procedures I highlighted earlier, such as suturing, incision and drainage for an abscess, or casting. And specifically in like an emerge department, you'll see the PAs are doing a lot of the procedures because it frees up the time for the docs to deal with some of the more acute patients in acute, major, or the resuscitation area. And then the PAs, again, as like kind of going along with that, the PAs play a big role in streamlining the patient flow. And there are other non-clinical aspects of the PA role that kind of helps the department run smoothly. And then the last point for there about work-life balance is essentially like it depends. Like it depends the type of person you are. Some people are night owls, some people are early morning birds. Like it really reflects like the type of job that you choose. Some people like the Monday to Friday 8 to 4 or 9 to 5 job, while others like maybe just working 2 days and then you get 2 days off before you go back to work 3 days. And Emerge kind of provides you an opportunity to have a good work-life balance. I know some people who, when they get 3 days off, they just book a vacation and then they go on a quick trip. So there's so much flexibility in that sense when you work in Emerge. And on the flip side of that was ortho surgery. So my typical day or like a typical week as an ortho surgery PA was Monday to Friday, 8 hours. It's almost like an office job. I had my own office, and I would kind of start off the day reviewing the patient charts and then making notes, kind of like internal medicine. If you see you go to the ward and then you have your patients and you're going through the charts, and let's say like a patient who's post hip surgery, if their blood like hemoglobin's low, then you would make note of that. Go see the patient, see how they're doing, order the blood work to confirm, and then order them some blood. And then monitor them throughout the day and make sure that they're handling it okay, and then repeat the blood work after. So that's like an example of that. So I gave hip surgery as an example because most of my patients were perioperative care. So if they're coming in for, let's say, a hip fracture in Emerge, I would be responsible to go do the consult in Emerge and then work with the surgeon to consent them for surgery. So the surgeon would talk to them about the procedure and then consent them for surgery. And then the patient goes to the OR, and sometimes I could help out in the operating room with the surgery. And then the patient comes up to the floor, and then you manage them after the surgery, make sure they're medically stable. So ruling out any infection, any blood clot in the legs or the lungs, and then managing their pain, especially ortho. Like ortho surgeries are very painful for patients, so making sure they're like comfortable. And then you work with the allied health team, so the physiotherapists, pharmacists, occupational therapists, and get them stronger before they go off to rehab. So there's actually quite a lot of interprofessional collaboration on the floor as well as an orthopedic surgery PA. A bit different interaction than how it is in Emerge, but still the same somewhat collaborative approach. And then I think I covered the other points in terms of the variety, in terms of the scope. So a bit more rigid schedule. So it's Monday to Friday, you only get the weekends off, but I would say practice-wise, the intensity was a bit slower and a bit lower for ortho compared to Emerge. So that's kind of about PAs and a typical day in Emerge and ortho. I guess I can touch base to see if any questions before we dive into case studies.
Yeah, so 2 questions just before you do. The first being, you mentioned the difference between what doctors and PAs can do, right? That a lot of times with most things, right, with conducting histories like you have on the slide and all that, it can be done by PAs in the same way that it can be done by physicians. So a student is asking, more specifically within the realm of emergency medicine, what differences do you see between PAs and doctors?
In terms of, okay, so like in terms of, I guess like going through a case, let's say like a PA, once they see a patient, they would actually go discuss with the doc. But again, with time and with like, I work with, I think 60 docs in Emerge. So like getting used to every single one of their styles and then also earning each one of their trusts when I see a patient. It does take time because they need to get used to you. They need to know how you think about every cases, or like every different like presentations that come to Emerge. And then as they get more and more comfortable, the PA wouldn't be running the case by them. They'd kind of order the investigations and the doc's already dealing with another patient. And then you can order the treatment options. Of course, if you have any questions, you can still discuss it with the doc, because at the end of the day, it's kind of the doc's name on the file and you're kind of working collaboratively with them. Obviously, your name's still on the file, but I think that's kind of like one of the major differences. But in terms of approach, like at the end of the day, you're a provider, an Emerge provider as well. So you may approach something differently than the doc does. And you can kind of have that as a discussion and then see what's best for the patient and make that decision together. So it's more of a collaborative component, whereas if you're a doc, it's kind of you kind of making the decisions unless you want to go and discuss with a colleague. Versus as a PA, you're kind of expected to have that collaborative relationship with your supervising physician.
And then one more question before we move on to cases. So you mentioned that you were a kinesiologist beforehand, right? And that drew you to orthopedic surgery just because of the overlap with both being musculoskeletal. What about emergency medicine? What drew you to that field?
That's a great question. I actually was not interested in Emerge. I did my rotation and I was like, yeah, this is fun, but like, this is very intense. But it was actually a mentor of mine who I actually was going to pursue ortho surgery, another position, not this position. And it was actually a mentor of mine who was like, okay, like you got to think about your career, like like on the long run, like you want a few years of general medicine under your belt before you go into specialty. Because if I go into ortho, everything's going to be very ortho specific, and then you lose the general medicine you learn in PA school. So that was kind of why I chose Emerge for a job, like my first job. But then I actually, as I did more and more Emerge, I fell in love with it. Like I enjoyed the fast pace. I enjoyed the variety. Someone who gets bored easily if I do the same thing. And even in my 1 year of ortho, I was like, oh, okay, this is getting like pretty repetitive. And I actually picked up a few Emerge shifts during that year in ortho too, because I liked the variety and the intent, like higher intensity in Emerge. And then procedures, I really enjoy procedures. I've learned to love suturing. It's like a different type of medicine than just kind of like the clinical reasoning when you have a conversation with the patient, do a few quick physical exams and you're thinking about the case. A procedure is a bit more simpler in that sense, and that you just like, you see a laceration, you suture it, or you see a broken bone, you kind of put a cast on and it's a bit more hands-on. So I like that variety. But yeah, so I did it as like, okay, I want some general medicine earlier stage in my career, but now I'm like starting to like it. And it's hard to kind of let go of that. I know people say like you do Emerge for a few years, at least as a PA, first few years of your career, and then you kind of ease off and do a few more lighter stuff, or you can even consider family med down the line in your career. But I don't see that changing too much. And then my last reasoning was for my U of T role, I needed like a general medicine clinical perspective when you're teaching students about like general medicine. So it's nice to have the specialty knowledge, but general medicine kind of helps you in teaching as well.
Great to hear. Well, that's all for questions for now.
Okay. So let's dive into cases. I think we're doing okay for time. I think I have 4 cases, and it's a good mix of Emerge and ortho. And yeah, I guess I won't be able to see the participation, but Michael, you can keep me posted. So the first case is a 10-year-old boy who's coming in saying he's been having tummy pain for 2 days. It started around his belly button, and then now it's kind of moved to the right lower quadrant, which is kind of like the lower side of your abdomen on the right side. And then in terms of other symptoms, he is nauseous, so that's the N, and he has been vomiting. He vomited 3 times today and once yesterday. And then he also has reduced PO intake, which means he's not eating as much because he's been super nauseous. Mom took the temperature, it was 38.4 at home. She did give him some Tylenol. And she's also noticed that the bowel movement, so his stool is also slightly loose. So she would say he has diarrhea. But there's no complaints about with peeing, and no chest pain or no problems with breathing or no testicular pain. In terms of past medical history, he is a healthy boy. He has had no previous surgeries and all his immunizations up to date. He doesn't have any allergies to medications. And then you move on to physical exam, and you've noticed that his in the emerge department, his vitals are all stable. He doesn't have a fever because mom gave him Tylenol. His abdominal exam, it's soft, his abdomen's soft, but he is quite tender in the right lower quadrant, specifically at the McBurney's point. You do all the special tests and you notice that the other signs, so psoas sign, Rodsing sign, and obturator sign are all negative. You also notice that it's not rigid, the abdomen's not rigid, there's no signs of peritonitis, but he is guarding. Every time you try to palpate the right lower quadrant, he kind of contracts his muscle and he's guarding and trying to prevent you from kind of pushing where it hurts. His testes are normal and there's no signs of torsion or any hernias. So my assessment and plan for this is, so there's appendicitis, and I've listed like a few kind of question marks there in terms of what it could be. And then next steps, I've also kind of listed a few things there. But so that would include blood work. You could do a POCUS, which is basically bedside ultrasound. And then you consider fluids, pain management, and something for the nausea. And then consider general surgery consult. So I guess like knowing this and all the stuff in the assessment plan section, does anyone have any suggestions in terms of what their top differentials or what you think the diagnosis likely is? Like, let me know if anything pops up in the.
Yeah. While we wait, just because there is a bit of a delay, maybe we can go through one question. So
Sure.
If you could just go through a couple other fields that you know your colleagues are in. We've had emergency medicine quite a bit. Just with recent PA sessions, we've had some other PA sessions for dermatology, with one working in dermatology. So are there any specialties that maybe you have seen PAs work more in, less in, just so people can get like a sketch of the demographics, if you will, of where PAs usually work?
For sure. Yeah, that's a great question. I think it depends on the geographic location. Like in Canada, most are saturated in Ontario. We have quite a few PAs working in endocrinology because they have this organization LMC, which is very pro PA, and they've hired on like more than 10 PAs. A lot are in emerge, again, where there's a need. There you'll find PAs kind of filling the gaps, and there are more and more family med PAs that are growing because of the shortage of family docs. And especially with the shifts during the pandemic, like a lot of the family practices closed and patients ended up coming to emerge, but now we're kind of shifting back to what was pre-pandemic. So slowly we'll kind of have to fill in those gaps in care. So that's endocrinology, emerge, and family med. And then there are a few in like cardiology. So whether that's outpatient clinic or cardiothoracic surgery. Neurosurgery is another common one. So if you're interested in the brain and specifically the surgical management, or neurology, if it's like more clinic and non-operative management. I've seen quite a few in general surgery. I think that's like a common one as well. So they work in the hospital, similar to my ortho surgery stuff, but seeing more of the general surgery presentations. So a mix of emerge consults, ward management, sometimes even the clinics for post-op follow-ups and things like that. Gastroenterology, yes, but I haven't seen too many, at least in Canada. And then also even more specific, actually PEDS is a very common one too. So PEDS, whether it's outpatient PEDS clinic or sick kids hospital, is a very popular spot for hiring PAs in their emergency department. So, so that's a very common and popular option. And then lastly, yeah, some of those very niche specialties. So like radiation oncology specifically, not just like in the hem-onc, medical oncology, like different specific ones at Princess Margaret. So they have quite a few PAs there. And then plastics and cosmetics, like, so that's a different branch as well. So I would say the top ones would be family med, emerge, and ortho surgery and general surgery. I think those would be the top ones. But again, wherever you find a doc, you can find a PA.
That is true. So from our chat, we have mainly appendicitis.
Yeah, yeah. Very good. Yeah. I apologize. Like, this is supposed to kind of come in as like in order, but then I just realized that it's a PDF, so it took away all those transitions. But we can still go through this, and I don't know if I can really cover the bottom, but like what you can say what your top differential is, and again, it's more so kind of going through that the top to bottom, so going through the history and then the physical exam, and then starting to think about the differentials. And this is a perfect example of how like an emerge note would look like, because you have all this stuff, but then when it comes to assessment and plan, you have like abdo pain is kind of what they showed up with. You can't definitely say it's appendicitis without really doing this stuff. So you have your kind of thought process: is it appendicitis? Is it just gastroenteritis, which is common in kids? And then what are you going to do next? So, and then you're obviously going to do blood work, and then poking a 10-year-old is going to be very painful. So, and very difficult too. So you have to get the IB nurse to come in. So these are the things you're kind of thinking about. But you can order an ultrasound, but why not just do a bedside ultrasound? So that's a tool that's very commonly used in emerge. And then a common kind of trio of medications would be like, you want to give them fluids because he's been vomiting and he's had like looser stool, so potentially diarrhea. Manage the pain because obviously that brought him in, and then because he's vomiting, you want to give him something to kind of settle that down. And then the general surgery consult kind of gives it away, but you have to think ahead, like what time of the day is it? You don't want to bother the general surgeon at 11 p.m. So if you're already thinking and your clinical suspicion's high for appendicitis, then kind of give them a heads up early on. So this kind of gives you an overview of what it is like in emerge. We'll move on to case 2, which is a bit more straightforward. You don't have to really think about the differential. So again, procedures, and this is kind of why it's nice to have this mixed in with your more complicated patients, because you kind of know what you're dealing with, and you just have to make sure the procedure component is where you're kind of spending most of your time in. So we have a 35-year-old right-hand dominant gentleman who comes in, and he said he has a laceration in his left palm. It's about 5 centimeters, and he said he was he was about to get ready to cut some vegetables, and then it was a clean knife, and he actually ended up cutting his palm in the process. And obviously it's painful, but the bleeding is controlled with the dressing done at triage. And then in terms of his tetanus status, he's like, I don't know when I got it. It must be when I was younger. So it's definitely more than 10 years ago. And then he doesn't have any numbness or tingling associated with this. So you can see that the history is relatively kind of focused only around the lac and the functional aspect of that, instead of asking him, because you probably want to ask what time it happened. So you want to make sure it's within the window. So let's say in this case, it's less than 24 hours. And then you're not asking them about chest pain, shortness of breath, although sometimes I do ask about dizziness if they lose a lot of blood and if they feel lightheaded. You just want to make sure you're ruling that out. And then if it's outside of that critical window, making sure there's no signs of infection, so no fever. And I also ask if they have diabetes. So you can see this patient has insulin-dependent diabetes and they're on insulin. So that's important because it increases their risk of infection and other complications. And then I also ask if they are a smoker. So in this case, this patient is not a smoker. You ask for allergies because you are going to inject some freezing. So make sure that they don't have any allergies. And then you specifically ask, like, have you been to a dentist where you have to get freezing done? And have you had any reactions to that? So that's kind of my approach to that. We talked about immunization, and then you go on to exam. So we have switched to Epic EMR, which is always great because with EMRs, you can just kind of take a picture of the cut and add it to your note, not like what you would do with paper charting where you have to attempt to draw it. And I'm not much of an artist, so that was difficult, but Epic has changed that. So his vitals are all stable. And then again, so see if it was paper charting, you would draw the hand, or you can take a picture, and then we kind of document the length of it. Always document if they're distally neurovascularly intact. So that means that their the nerves and their vascular status is good. So you can check for cap refill. If it's the palm, you want to check for cap refill. And then if they have sensation of their radial, median, and ulnar nerves in their fingers. And then obviously the grip strength would be reduced because the cut's in the palm. So they wouldn't want to kind of stress that area more. FDP and FDS is flexor digitorum profundus and flexor digitorum superficialis. So two important tendons anywhere in the hand. You want to make sure that you check if they have flexion of the last kind of like the last tip, the distal tip, and then also in the middle of the finger so that you can see that some people, if there's like a tendon damage, they won't be able to flex. And you want to document that because that's important for closer follow-up with the plastic surgeon. And then lastly, no tissue loss. If you're missing a chunk of tissue that you can suture together, then you have to kind of document that so that you can keep track of whether that happened as part of the initial injury or something that happened long term. So lastly, assessment and plan again, laceration, pretty straightforward. This one, you're kind of putting a definite diagnosis there because it's right in front of you. And then you would write your procedure note where you talk about anesthesia. So local anesthesia, let's say you're injecting lidocaine, 2% without epinephrine. And you would, I don't know, you could put in like 3 cc's locally, and then you irrigate it with normal saline, make sure it's clean, there's no foreign body identified. And then for the hand, you would suture it, you would specify the type of suture you use and the size of the actual suture, how many sutures you put in, the technique you used, and then the dressing that you did after. And then you also want to like document that you spoke to them about the aftercare. So it's easy to do the procedure, but when you send them home is kind of what determines if it's going to get infected or if the prognosis is really good. So I like to tell them like how many days before they have to get the stitches out if it's non-absorbable. And then obviously keeping it clean and dry and keeping it covered at all times. And then what to monitor for in terms of infection. So like make sure there's no redness, there's no pus coming out. If there's any fever, anything like that, you come back to either emerge or you follow up with your family doctor to get some antibiotics. And then I put an asterisk with plastics follow-up. If there was anything that the tendon was damaged or you have some like you're like, oh, I think this patient would need like a proper follow-up because he's diabetic, he's prone to infection or something like that, then you could obviously make that referral. And then again, depending on the mechanism, let's say he was cutting meat, and then as he was cutting meat, it was like a dirty knife, and then he cut his hand, then you would consider potentially putting them on antibiotics because it's a high risk. And then of course, with this patient, you'd also want to update their tetanus. So giving them that Adacil or Tdap, just making sure that their tetanus status is also up to date. So that's case 2. Any questions about that?
No questions.
Okay. I'll kind of, we have 2 more cases and I want to make sure I leave some time for any other questions that come up later on. So case 3 is 66-year-old right hand dominant female, and she's here with right wrist pain. She said she had a trip and fall. She didn't hit her head or lose any, she doesn't know if she hit her head, but she didn't lose consciousness. And she has a mild headache and mild kind of lateral neck pain. So it's not in the middle of the neck, which is important. And she sustained a Fouche injury, a very common term that's used in both ortho and emerge. So Fouche stands for falling on outstretched hand. And it's like a mechanism where you're kind of falling with your hand outstretched, essentially. And it puts you at risk for a specific type of fracture, which is kind of given away at the bottom over there. But obviously she's presenting with right wrist pain and swelling, and there's actually an obvious deformity, and the deformity that you're looking for is a dinner fork. So if I could kind of try to demonstrate it here, if you're falling like this on the ground, then this bone kind of goes up and you'll have this like dinner fork deformity, like you would with a dinner fork. And that's a common kind of obvious deformity that you would see for a Colles fracture. It's important to note that there's no open laceration, so the skin is not thin. She doesn't have any bone kind of coming through the skin, and there's actually no like wound around this the fracture site as well. In terms of paresthesia, so no numbness, tingling, pins and needle sensation, so that's good. And then obviously there's reduced range of motion because her wrist hurts and it's quite swollen. In terms of review of systems for this patient specifically, we do cover other systems because it's not like we know exactly what happened. She tripped and fell. So you want to make sure there was no chest pain, shortness of breath, or dizziness or anything around there. So contributing to that fall. And then obviously no fever, nausea, or vomiting. So fever because you want to rule out any infectious causes of causing the fall, and then nausea, vomiting because of the fall. If she did hit her head and there was a head injury, you may potentially exhibit some of these other symptoms instead of a direct headache. Past medical history, she has quite a few. So she has hypertension, which is high blood pressure, high cholesterol, dyslipidemia, diabetes mellitus, and then she also has atrial fibrillation. So in terms of meds, they kind of correspond to that. So hypertension takes candesartan, high cholesterol, she takes rosuvastatin, and then for diabetes, she takes Janumet, and then atrial fibrillation, she takes Eliquis and bisoprolol, so rate control and blood thinner to kind of prevent any clots. So those are her meds. Allergies, none. Immunizations up to date. And then you can see that on exam, her vitals are okay. And then you do a neuro exam because you don't know if she hit her head. So I didn't put the whole neuro exam because it would probably take up the whole slide, but it's unremarkable. All her neuro stuff is, so you're checking cranial nerves and weakness and everything is all normal. Except for the wrist. And then MSK, you can see that it's the same thing as subjective. So reduced range of motion, strength, and all that. And then you also note that there's no scaphoid tenderness, which is very important to note for this type of mechanism to make sure that the scaphoid bone is not tender. And then also commenting on the skin. So this one is a Colles fracture, and you would do an x-ray, and considering her age 66, it depends on the provider, but I think it's safe if you want to do a CT head, make sure that there's nothing else, especially considering she's on blood thinners. That is a high risk, and she is over the 65 years old rule. And then considering pain management, and then something for the nausea, because usually you would give strong pain medications for these patients with their fracture, and you want to make sure that you combat that with the antiemetics to prevent her from feeling nauseous. And then you would actually consider putting them, giving them conscious sedation, and then reducing that bone to align it quite well, even though like depending on the type of fractures, I wouldn't get too much into detail with that, but you want to make sure that it's in the right alignment so that it heals well, and then put a cast on it to hold it in that position, and then talk about cast care before you kind of discharge the patient with fracture clinic follow-up. So that's a very common case in emerge. And then on the flip side, you also see it commonly in ortho, where you would follow up with a distal radius fracture and make sure that it heals nice, or potentially consider surgery if it's an active fracture. Any questions before the last case?
No questions.
Perfect. Okay. The last question or last case is an 85-year-old gentleman who is coming from home. He said he got up to go to the bathroom at night and he fell on his right hip, and now he's presenting with right hip pain. He's been unable to walk since then, and he actually had to drag himself back to the room and on the ground, and then he called 911. He didn't hit his head when he fell down, just his right hip. And so he has no headache, no neck pain, no tummy pain, and no problems with peeing or pooing. So he didn't really hurt his back either. In terms of past medical history, he also has those 4 conditions and is on those medications. So Xarelto for the AFib for this patient. And again, that's a blood thinner. And then allergies is none. And then on exam, you do see that his right leg is ER is externally rotated, and then it's also shortened. And then you do notice that his distal neurovascular intact. So there's a good pulse. He can move his ankle. He's able to feel his foot. And then there's no open wounds or sores. And then you also make sure, because he fell, he did say he doesn't have any neck pain, but just make sure that his C-spine, so cervical spine, is non-tender right in the midline. So quite a typical story, believe it or not. When I did my ortho surgery, this was like 1 in 4 cases, or maybe 1 in 3 cases that I saw, where elderly patient falls, or sometimes they actually feel a snap in their hip before they fall if they have weak bones. And their legs usually shortened and externally rotated. It's just not the same length, and it kind of is rotated in one way or the other. If it's a hip displacement, it's a different presentation, but again, that's less common, I would say, in senior patients. So you have a hip fracture, you just got to get the x-ray to confirm that, and then you can send them for surgery, keep them, NPO means like nothing by mouth, get them into, give them some antibiotics before the surgery, get them into the OR, fix the hip, and then you would have to monitor them after the surgery on the ward, make sure they're comfortable in terms of pain management, and then they get stronger with physio before they go off to rehab to get a bit more strong before going back home. So that is another, again, typical story, emerge and ortho, and something that's like a good representation of those two specialties. So those are the 4 cases. Again, sorry that the diagnosis popped up and it didn't kind of do it in stages, but hopefully it was still informative. And then again, like after I finish it, I just like to get gauge interest to see if there's any changes after kind of learning about the profession and considering it as a career option. But I will skip this and then thank you again for your attention. And then I dropped my Instagram handle there. So if you have any questions, you can reach out and ask. And I also share my PA journey from when I started PA school on there and now as a practicing PA, if you're interested in checking that out.
Well, first of all, thank you, Aurthi, for getting this all together. A lot of people love seeing cases, and I learned quite a bit from them just going through those 4. So we really do appreciate your time, and definitely for those who are either interested or considering becoming a PA, definitely shoot her a message if you have any questions. We appreciate you for giving that resource. But just to start questions off, we wanted to ask, you mentioned how earlier on PA school is like a condensed version of medical school. We've heard the same from a lot of speakers, and each speaker and really everyone will have their own ways about going about that, right? Study strategy wise. So how did your study strategies change when you hopped into PA school?
Yeah, that's a great question. And it's funny because now I'm then thinking about it. You had staff from McMaster and Malika from University of Manitoba. So different programs, and that actually highlights the different teaching as well. So I'm sure staff has covered, like Mac is more PBL, so problem-based learning. And I'll talk about the U of T program. We do have like one aspect of problem-based learning. So U of T program is mostly online and a few in-person components. So that in itself changed my study strategies because there's a lot of self-discipline that's required for you to be at home, watch the lectures, but then also do your own studying and catch up with the lectures outside of those synchronous sessions. And then EPBL, so electronic problem-based learning, was one component of one course out of 5 courses in a semester. So that kind of gives you like an idea of like how dense the U of T curriculum is. So you had anatomy, let's say physiology, clinical skills, and then within clinical skills, you have like the clinical component, and then you have the EPBL component. And then we had LCE and then PA professional competencies. So you learn about the PA profession, you do placements, and then you also have these courses running along that. So obviously it's very busy. And I think the way I kind of approached it is like making sure that I had a good working space. So at home, because this is not like I'm going to class and I'm actually learning in a classroom setting. So I had to make sure that I had like a good workspace. And then I also schedule my days such that like I work well in the early morning. So I would like make the most out of my early morning. And it's funny because I still do this as a working clinician. Like I get most of my work done earlier on in the day because I know I'm going to fade later on in the day, while I see some of my colleagues are like, this is the time I'm like the most productive at like 11 p.m. And I'm like, I'm in bed, like I'm sleeping by that time. So there were times that I got up at 5 a.m. to study, because I knew that even though I was sleepy, like that's when I would retain most of the information. So I'd like get like maybe 3 or 4 hours of studying done, and then I'd take a break. And usually that break would be whether it's for like a meal or whether it's like for a coffee with like a friend, or if I'm going to the gym, then that would be my break. And then I'd like take an hour or two, and then I'd come back and study for a few hours, and then take another break, and then another few hours. And as crazy as it is to say, it was 2 years of basically, or at least my first year was that, like chunks of studying with like a few social activities here and there, unless I had a placement for the whole day. And then you're basically studying from when you wake up to when you sleep, with a bit of a break when you're kind of like, I don't know, like I watch Grey's Anatomy because it's kind of technically still studying when you're watching medical stuff. And then you would go to bed, go to sleep, and then repeat the next day. And some of those one-day placements were a good variety to kind of break that studying cycle. And then obviously when you have an assessment, you would go take the exam and then take some time off, but shortly after you're kind of jumping back in, and because there's just so much material you have to study. I'd say in terms of study techniques, I recently learned there's actually no such thing as like learning, what's the word? Like being a visual learner versus auditory learner. There's like research on this, but I still believe that like there's different learning styles for certain people. I like when I see something, it sticks to me better than when I hear it. So I like lectures where it's kind of laid out on the slide more so than just hearing the presenter talk about it. But I've had friends who like listen to lectures as they're going to bed. They're like listening to the clinical pearls and all that stuff when they're going to bed. Like that kind of reiterates it and consolidates it in their memory. And then lastly, I would say kind of group studying was another thing that I took advantage of in PA school that really helped me. And I basically would, we split up the workload because the lecture material was so much. We'd all cover kind of portions of it. We'd compile it into one document, we'd study it. And then before the exam, we kind of did group studying where we'd ask each other questions, pretend we're like the prof, like kind of asking the test question, and then you would have to explain it verbally. And so obviously instead of like an MCQ question. And I found that to really help. And then you kind of do that studying in second year, and you would still, you would kind of apply it to clinical cases, and then you retain it. And then now you go into practice and you kind of figure out a way, because at the end of the day, like undergrad to PA school, you're figuring out a way you can learn for long-term learning, because medicine is like you learn for your whole life. So you got to figure out a way that you can kind of learn from cases and then keep that up, instead of just kind of memorizing a textbook, going into an exam and kind of just like dump that out after, right? You're not really understanding the material. You have to understand it for medicine. So that is kind of my long-winded answer of how my studying changed and how PA school experience is. But yeah, definitely different from undergrad, I would say.
There's definitely a lot of insight to that. I can attest to how, you mentioned there's kind of like a study schedule or a study in the same way that we might have like a sleep schedule, a regular sleep schedule. We should have a study schedule going for ourselves. So if we're more of a morning person, take advantage of that. I noticed that in myself when I was studying for the MCAT. So after picking up on it, you definitely want to make use of it. But outside of that, I wanted to also ask about how you distributed what you did when you did study. So was it more of a focus on practice questions? Some people use flashcard apps. What did you do personally?
That's fun. I'm laughing because I know so many people use all these different study techniques. There's like flashcard, there's like online apps where you can like make cue cards and stuff. There are people who do like games, and I honestly, I would make notes and then I would read through them, and just looking at the notes instead of kind of like listening to the lecture really helped me. And then the group studying was kind of my, like, I guess, fancy way of, so like the fancy stuff. Like I didn't really do cue cards. I didn't do any, like some people do Jeopardy. It's like, it's amazing how creative some of these students get. And in terms of practice questions, I would say that really helps in second year, because you have these end of rotation exams. So every time you go through a rotation, you have to do an end of rotation exam, which is, we're in Canada and we actually use PAEA, which is an American based test. So some of the things are like, some of the concepts are not concepts, some of the tests and measurements are different, but other than that, like the concepts are relatively same. So you have to keep up with your material to do well on those end of rotation exams. So I did a lot of practice questions in second year. And then leading up to the certification exam, I did like quite a bit of practice questions, not only because you want to get used to that way of thinking, but because you have to build the stamina to take a long test, similar as you would for like MCAT. So you have to really do a lot of practice questions and make sure you're actually like, it's quality thinking for each of the practice questions as you go through more and more of them, more and more practice exams. And that way you're not kind of like fading closer to the end of the exam, and you become more efficient with your time. Because our cert exam is scheduled such that you only get 2 minutes per question, I think. So you want to make sure that you're within that time limit, and the stems are quite long. So you have to understand the patient case and what is being asked and things like that. So yeah.
Another thing is that when you did graduate, it was in the middle of the pandemic. What was that like, navigating the job market there?
Yeah. Yeah, definitely a different experience. So when the pandemic hit, like 1/3 after I completed 1/3 of clinical year. So most of my training actually in the clinical year was affected by it. I missed out on my OB rotation, and then we were online, just virtual learning without any placements for a bit. So I think that kind of stumped some of the clinical learning, but regardless, we finished clinical year. And then I honestly think the pandemic helped out with the like advocating for the PA profession in Canada. So more and more jobs kind of popped up because people were burnt out. They wanted to hire on a PA, or Emerge was swamped and they wanted to hire on a PA. So different reasons like that. And when I applied, I actually applied to a lot of jobs because I wanted to keep my options open. And I think I got like quite a decent number of options in terms of, I think I applied to 20 positions, and that speaks to how many opportunities were out there. And I think I got 18 offers. And again, it was super hard to kind of figure out what I wanted to do. Some of them were even up north because I was like, oh, maybe I want to like go up north and work for a couple of years and get that experience. And then narrowing it down, pros and cons, and then I narrowed it down to 2 options. And the pandemic did play a role there because one of them, the other option was ortho surgery outpatient clinic. And because of the pandemic, they couldn't run the clinic. So they're like, oh, would you be interested in kind of going to the hospital and helping out? And then it was kind of, it transitioned into a COVID kind of ward management role, which highlights that PAs can be very versatile. They can kind of help out wherever there's a gap in care or wherever there's a need, but that was not what my interest was. And so I was kind of going through there, and then I landed with the emerge position. And some of the other positions, they were like either too far or it just didn't work out in terms of like timing or different reasons. But yeah, I would say like the pandemic kind of helped in a way because, and most of the interviews were like virtual. So that helped for you to explore like different options instead of driving wherever for the in-person interview. And it created more job opportunities for PAs, I would say.
For students, especially those who are interested in applying to Canadian PA programs, I know it's still a growing profession, but are there any associations for the purposes of networking that they might be able to get involved with and get either in touch with a PA student on a specific program, hear more about what the program, how the program runs, curriculum, etc., from a student going through it, or a PA themselves, a practicing PA?
Yeah, no, another great question. I would say for Canada, okay, so there's a few options. So obviously social media is key. Like there's so many, like when I started it, I think there were only a few PAs sharing the journey. Now there's so many PAs and everyone with different specialties of practice or different programs and different experiences because of the background they come in. Like my background is kinesiology. Some people were like paramedics for like 20 years before they pursued PA school. Physios, medical clerks, IMGs, so who are like doctors from other countries who come here and they pursue the PA profession. So everyone's journey is unique and social media kind of highlights that. CAPA is like the Canadian PA Association. That's a good area to kind of get more background about the PA profession. So their website's pretty informative in that way. They have a conference where you can network with PAs. There's also like a Facebook group that's like, I think it's a Canadian pre-PA Facebook group. So if you're interested in PA profession, you can kind of post on there if you want to do a shadowing opportunity or like an observership, or if you want to network. A lot of people are quite active on there, and it has like most of the Ontario PAs and PA students and pre-PAs. Like there are quite a few of like a good mix over there, so they can answer your question. And yeah, so currently there's actually 3 schools, but they're actually growing. So there's more schools popping out. There's one in University of Calgary, and then they're also opening up out east in Nova Scotia as well. So more programs will come up, and then there's actually more PAs practicing out east as well. So that might be like a unique opportunity. And I think one thing about it being a growing profession is as they're kind of launching some of these pilot projects, they're recruiting PAs. So that's like more job opportunities for you to kind of explore and travel around, but also like pursue a job and also pursue like a profession that's kind of relatively new in whatever area that you're practicing.
And then just to wrap up today's session, this was a really nice session. One more question just before we close, and that is, have you or any other colleagues considered going back and training in another profession? So the student asks if someone has transitioned from being a PA to a doctor, or possibly I can add on to that with PA to any other like provider position outside of that specific facet.
Mm-hmm. Another great question. I love these questions. So I would say Like it depends. So it depends kind of what people are using or people are seeing PA as. Like I think usually, generally speaking, people would say do not use PA as like a stepping stone for med school. Like if you already know you want to be a doc, kind of don't apply to PA school because you're taking that opportunity away from someone who genuinely wants to be a PA. That being said, I do know a lot of my colleagues and friends who had that like epiphany later on. So they did PA school because they wanted to do medicine, they wanted to be a PA. And then when they entered practice, they're like, you know what, maybe I want to be a doc because of the way the practice, the dynamic works. And that's fine. And what they do is they end up, the two that I know actually just did 2 or 3 years of undergrad, depending on the school they applied to. And then they went back to finish their undergrad and applied to med school, got in. And it's always great because now they go into med school with this knowledge of like the potential of a PA role, and they advocate for the PA role as they're kind of going through med school. But if you think about it, you've already been through med school in a condensed version. So you're going through it in a more lengthy version, which makes you shine in that program. And you actually get to learn more because you're just adding more to what you've already known. So it's almost like going through the curriculum twice with more time, more detail. So you become even more like, more well-informed and like a well-rounded clinician. So I guess if you look at it that way, it does kind of help, but then you also have to consider like the number of years that you're putting in. If you want to choose a specialty. So the one PA who did end up going and she worked in neurosurgery and then she went back to med school and then actually did anesthesiology. So that's like many years of specialty training on top of just the general training as well. So that's that. And then I think to answer your other question about other professions, though, one thing that I noticed, and I actually have been able to kind of partake as well, is that you do your 2 years of PA and you don't have to necessarily just be a PA. There are different kind of areas that you can explore. Some people go into research. So they do research, like clinical research, and they work with their supervising physician on that. Some people go into academia, which I was interested in because I was involved with the program because I was a class rep and I worked closely with the program members, especially kind of navigating through the pandemic. And that kind of gave me the opportunity to work with the program director and the medical director, and then interested in teaching as well. So that kind of landed me like that position I'm in currently. And I do a lot of teaching, which I really enjoy on the side of clinical medicine. Some people go into public health initiatives, so quality improvement, how to make healthcare better in terms of like the different population that they serve. So that's also another interest. And then some people also pursue an MBA. So they do their master's, and they can do a master's in public health education. Some people do MBA and have this like health admin kind of perspective, and then they kind of do part admin and part clinical work, or sometimes full admin managerial stuff in terms of clinical work. So there's actually a lot more flexibility than you would think when you're like, I want to be a doc or I want to be a PA. But at the end of the day, you don't have to be just one thing. You can be multiple things. And that variety gives you more like fulfillment in your career. And also kind of helps you find things that align with your interests. So like I was always interested in teaching, which I don't get as much in clinical world as much as when I actually teach students, which is fulfilling. So yeah, I think that answers your question.
It does. That's just a great summary of different ways that people can get involved. It reminds me a lot of, I've heard of quite a few nurses who transitioned from nursing to med school, and they talk about how having that background knowledge is just a great solid foundation that not everyone is coming in with. And in fact, most people are not coming in with. So they have a head start on things and they understand the perspectives of other providers, which is even that much better. So I really do appreciate that insightful answer. I do have some last reminders though, before we do close for our shadowers. So for those of y'all who are new, we do have a quiz, and that is posted at the very end of each of these sessions. It's now posted in our chat box. It's also available on our virtual shouting page. And the third place that you'll find it is under our video description. So either of those places or any three of those places, they work. The same Google form. You have to have 6 or more questions correct in order to pass. And once you do pass, you'll receive a certificate that will be sent to the email address that you list on the quiz. We do recommend a personal email like a Gmail or a Yahoo account. And it will be due this Sunday, July 16th at 11:59 p.m. Central Standard Time. If you happen to not receive the certificate, and it should be sent immediately if you do pass, if you happen to not receive it, please do feel free to email us. But before that, we do recommend checking your spam folder just in case. For our next shadowing session later this Thursday, we will have a nurse practitioner, Morgan, join in. She's specialized in medical, surgical, and cosmetic dermatology, and we'll see her at a regular time of 7 p.m. Central, and she will join us later this week, I believe, on the 13th, Thursday the 13th. Again, we post these flyers for each of our speakers on our Instagram page and also on our listserv, where we do have the same flyers, just in email format. So either way works. But I do recommend, if you're interested in joining us for more sessions, definitely hop on, either follow us on Instagram or subscribe to our listserv to hear more. But that is all. Thank you, Aurthi, again for getting this all together. Let's hear some thank yous in the chat for her. And also, definitely, y'all, make use of her contact. If you'd like to get in touch with any questions, feel free. We've had quite a few Canadian PAs, 3 actually so far. And that just goes to show, just like you were saying earlier, how social media gets the word out there just over our platform. I'm sure there's been more case scenarios of that too, but that is all. Thank you so much, Aurthi, for getting this all together.
Thank you.